Today we're talking about pain management in preparation for the board exam for dentistry. Let's see here. I guess I won't be able to see myself. So I'm covering pain management and local anesthesia at the INBD level. This means we're not just memorizing facts, we're understanding mechanisms, clinical consequences, and anatomy all together. So the board loves to test anesthesia by asking why something failed, why a patient is at risk, or which nerve wasn't anesthetized. So everything today feeds directly into those questions. Let's begin. So today, the overview, we'll be going over the mechanisms, systemic effects of epinephrine and local anesthetics, the trigeminal nerve anatomy and anesthesia targets, high yield clinical correlations, and first, the primary action of local anesthetics. So the most important sentence you should know about local anesthesia is this: they prevent the generation and conduction of a nerve impulse. So think of this as creating a chemical roadblock. The nerve may be stimulated at the periphery, but the signal never reaches the brain. If you understand where and how that block happens, you can answer almost every mechanism question in the INBD exam. And so we go into resting potential. And at rest, the nerve sits about 70 or negative 70 millivolts. This negativity exists because the membrane is relatively impermeable to sodium, but permeable to potassium and chloride. So the board loves this concept. If sodium can get in, the nerve stays quiet. That's the baseline state local anesthetics are working against. Depolarization, when a nerve is stimulated, sodium channels open, and sodium rushes in, and the membrane potential rises. Once the nerve hits threshold, about negative 50 to negative 60 millivolts, the process becomes self-propagating, and sodium permeability increases dramatically. The membrane potential reverses, peaking at about 40 millivolts. And so this is the exact step local anesthetics are designed to prevent. The action potential ends when sodium channels inactivate and potassium permeability increases. So depolarization is sodium-driven, repolarization is potassium-driven. If sodium never gets in, none of this happens, and that's anesthesia. So specific receptor theory, this is the most accepted explanation for how local anesthetics work, and local anesthetics bind to specific receptors within the sodium channel, not just the outside of the nerve. This detail matters because it explains why the drug must first get inside the nerve to work. So sodium channels are lipoglycoproteins with aqueous pores and gates. When the gate is open, sodium can flow passively. Local anesthetics don't destroy the channel. They simply block it, preventing sodium movement. Sequence of sodium channel blockade, the sequence is high yield and very testable. And so first, calcium ions are displaced from the receptor site. Then the local anesthetics bind the receptors. This blocks sodium conductance, slow depolarization, and prevents the nerve from ever reaching threshold. No threshold means no propagated action potential. This is the conduction block. So local anesthetic molecular forms. So all injectable local anesthetics exist in two forms: an uncharged base, noted as Rn, and a charged cation, RNH+. So understanding what each does is critical to explaining why anesthesia fails. So the uncharged form, Rn, is lipid soluble. This is a form that diffuses through the nerve sheath. Once inside the axoplasm, the drug re-equilibrates, and the charged form, RNH+, is what actually binds the sodium channel receptor. So diffusion and binding are handled by two different molecular forms. So pH and anesthetic effectiveness, we have where infections come into play. Lower pH shifts from the equilibrium toward the charged form. That means less Rn is available to cross the nerve sheath, so anesthesia is less effective. If you ever see an INBDE question asking why anesthesia failed in affected tissues, this is the answer. So vasoconstrictors, what is their purpose? Local anesthetics are vasodilators by nature. Vasoconstrictors like epinephrine are added to reduce blood flow, slow systemic absorption, prolong duration, and reduce toxicity. But what helps locally can cause systemic issues, especially in cardiac patients. So epinephrine receptor effects. Epinephrine acts at both alpha and beta receptors. Beta 1 effects on the heart are increasing heart rate, contractility, cardiac output, and importantly, myocardial oxygen demand. Low doses can cause beta 2 mediated vasodilation, while higher doses cause alpha mediated vasoconstriction. So epinephrine also increases pacemaker irritability. That's why dysrhythmia has become a concern, especially in patients with underlying cardiac disease. So in patients with severe atherosclerosis, coronary arteries can't deliver enough oxygen to meet the increased demand epinephrine creates. This mismatch can cause angina, myocardial infarction, dysrhythmias, and stroke. This is the clinical reasoning behind epinephrine limits. So pain versus epinephrine. Pain itself can cause the release of endogenous catecholamines, often at levels 40 times the baseline. So paradoxically, poor anesthesia may be more dangerous than carefully dosed epinephrine. The takeaway, profound pain control is cardioprotective. Certain conditions represent major red flags. Blood pressure being greater than 200 over 115 millimeters of mercury, MI within 6 months, unstable angina, severe refractory dysrhythmias, uncontrolled congestive heart failure. And these patients either require extreme caution or avoidance of vasoconstrictors. Maximum epinephrine doses. For cardiac patients, ASA 3 or 4, the maximum epinephrine dose is 0.04 milligrams per appointment. You must know this number cold. It shows up constantly. So this is equivalent to 1 cartridge of 1 to 50,000 epinephrine, 2 cartridges of 1 to 100,000, and 4 cartridges of 1 to 200,000. So everything in dental anesthesia revolves around cranial nerve 5. The trigeminal nerve has a small motor root and a large sensory root. Understanding where these branches go explains both success and failure of anesthesia. The motor root travels with the mandibular division and exists via the foramen ovale. It innervates the muscles of mastication, masseter temporalis, and the pterygoids. Additional motor muscles include the mylohyoid muscle, anterior belly of digastric, tensor tympani, and tensor villi palantini, which is my favorite. And these are not anesthesia targets, but they appear in anatomy questions as well. The sensory root divides into V1, V2, and V3, the ophthalmic, maxillary, and mandibular divisions. So most dental anesthesia involves V2 and V3. V1 exits via the superior orbital fissure and supplies the forehead, eyelids, and eye. It's not targeted in routine dental anesthesia, but can be affected during high-level blocks like the gout gates. The maxillary division V2 exits the skull through the foramen rotundum and passes through the pterygopalatine fossa. This division supplies the maxillary teeth, sinus, and palate. So key branches include PSA, MSA, ASA, nasopalatine, and greater posterior palatine. The classic INBDE question involves failure to anesthetize the mesiobuccal root of the maxillary first molar, often due to the MSA. V3, the mandibular division, exits through the foramen ovale, supplies mandibular teeth, tongue, and soft tissues with their sensory and motor innervation. The inferior alveolar, lingual, long buccal, mental, and incisive nerves all come from V3. Knowing where each one runs explains exactly what tissues remain sensitive. So the inferior alveolar nerve enters the mandibular foramen and supplies teeth to the midline. The lingual nerve lies anterior and medial and is often anesthetized simultaneously. The long buccal nerve supplies buccal gingiva of molars, often missed. The mental nerve supplies the chin and lower lip. The incisive nerve supplies anterior mandibular teeth and can be anesthetized by applying pressure after a mental block. So anatomic variations include a bifid mandibular canal in 0.95%, so less than 1% of patients, and this can cause repeated IAN nerve blocks. Also, the mylohyoid nerve may provide accessory sensory innervation, especially to mandibular incisors. So the key takeaways for the INBDE are that local anesthesia are never, well, the question.
Science didn't stop working. We just stopped asking the right questions. Hey, my name is Matt. I'm a dental student, endurance athlete, and lifelong student of the human body. And so for a long time, science was about curiosity and about understanding reality, not defending institutions, trends, or funding. Somewhere along the way, science got fragmented. Nutrition here, medicine there, psychology somewhere over there. And now nobody's connecting the dots. So here I am. I'm not here to smell miracles or sell you them. I'm not here to reject science. I'm not here to finish the sentences science started. On this channel, we talk about the human body as an integrated system, health, performance, and recovery, consciousness, perception, pattern recognition, and why real science requires humility, curiosity, and courage. If something works, we study it. If something doesn't, we question it. And if something feels off, we ignore it. I don't ask you to believe me, I ask you to think with me. I'm Matt, this is Science Without Blinders. Let's explore what's actually real.